In this presentation, I will focus on future perspective and unanswered questions. So basically, problems still associated with a time-limited trial. I have no conflict of interest for this presentation. I would there was a conflict of interest because that would mean there was a lot of interest in this topic, but fortunately, that's not really the case. Um, so, what are the characteristics of a time-limited trial? If you look at the keywords for this session, there are three keywords: outcome, therapy limitation, and admission. Of course, they are associated with a time-limited trial, but it's not the core aspect of why you would do a time-limited trial in a patient. I think the two core characteristics of a time-limited trial is uncertainty. Because if you're very clear what's going to happen, you don't need a time-limited trial. And it's in the cases where you are not sure that you use this brief period or longer period to make up your mind. And then again, it's also to avoid harm, not to do something for an extended period of time that doesn't make any sense for the benefit of the patient. And the key to end of life care in this already long time ago publication in JAMA is that there is a huge problem with dying in the hospital and especially dying in the ICU. And a fundamental fact is our inability to predict. So not only uncertainty, but those authors already said basically we're not even capable of predicting when death will come. And in the Eldeka study published in 2012, we already showed that we are very poor at predicting non-survival. In this study, we asked the attending physician to identify patients that would have a more than 85% chance of dying due to their critical illness. Actually, the mortality of this group they identified was only 69%. And the less than 15% was also very poorly predicted. Oh, this is too fast. And the main element of this is that we do not want to do or give patients inappropriate care. And of course, if it's unlawful, that's a different element. But it's also the disproportionate. We do too much to a patient where it doesn't seem to have, let's say, real benefit to the patient. And then, of course, we have the futile care where basically nothing is really making sense. And that's something that we want to avoid. And that's why we sometimes refer to a time limit to try to find out whether this is a disproportionate or futile trajectory. The problem is, and this is especially the case that I see in my practice in the United States, is where we started, and it's still there. Patients have the full right to refuse treatment. If they're mentally okay, they can refuse basically every treatment, even though the refusal leads to their death. But that has somewhat somehow turned around in, okay, I want everything done. Just yesterday, I was at the bed of a patient, and she said, I want everything done because I'm scared to death to die. That's, of course, not the right indication to do everything. Even asking for stuff that would never save her life. And so when you talk to families, you hear, I couldn't live with myself if we didn't try everything. So basically, the family members are turned into judges, like it's time for mother or father to die. And their time-limited trials can really help you to get around this uncertainty and create more clear perspectives for everybody involved. The perception we have as doctors of what patients think is also very dysfunctional. So this is different age groups, less than 50 to the very elderly, more than 80. And they ask, like, do you want life extending care, for instance, on a ventilator admitted to the ICU? And as you can see, the number of patients that would like to have life extending care decreases over time, over the age groups. And so, of course, the younger are much more in favor of extending their life than the very old, but still, in the very old, it's almost 30% that still wants to come to an ICU or do something to extend their life. If we then look at what we as physicians are willing to offer, already at the younger group, it decreases significantly. And at the higher age group, it's even lower. And so, where almost 30% wants life extending care, we are not willing to even offer it to less than 10%. And then the most striking elements of this is the physician thinks the patient probably wants. That's somewhat more in line with what the patient wants. But if we look at this aspect, the physician thinks the patient doesn't want, but actually the patient wants. And that's, of course, the conflict area. So in the very elderly, the majority, in many patients, we think that they don't want life extending care where actually the patient wants it. And of course, this is the element where we get into trouble when we want to communicate whether to do or not to do life extending care. And in especially these cases, a time limited trial could help. This is also, of course, a problem. If we do not know, if we do not talk to our patients, and we do not, let's say, get these elements clearly up front, it will be very difficult to communicate and to communicate about treatment and to decide about treatment. All of this is, let's say, taking place in a moral framework. And we're all aware that we have to do well and do no net harm. Remember, it's impossible to do intensive care without some form of harm. You need you need infusions, you need a ventilator, you need other interventions, and so basically, ICU is not observation. ICU is basically treatment, and so there is always net harm. And then, of course, respect autonomy. Respect autonomy is not doing what the patient wants. But especially not doing what the patient doesn't want, and then in a discussion, choose the best treatment that will ultimately, most likely, benefit the patient. All of these problems around the communication problems, the problems of patients wanting something else that doctors are not basically at baseline not willing to offer, result that, at least in the United States, a lot of patients die in the ICU, where basically, if you look at the data, these patients would be better off on the floor, or maybe even better off at home. And so, admitting a patient to the ICU within 3 days of their death, that's not really the mainstay of intensive care. And on top of that, once you are in the intensive care, and that's of course the element where we might induce harm, once you've started the treatment, it's not always easy to end the treatment. This was a study that Charlie Sprung did, and he pictured a withholding scenario, and then asked the participating physician, do you agree? And so if a medical decision is made that the patient's chances of surviving are extremely low, or the patient under present medical circumstances would not want continued, you may withhold this treatment. Still, 12% of the doctors think that that is not okay. And in withdrawing, it's even more. It's almost 20% that does not agree. That even in those extreme circumstances, they don't agree to withdraw treatment as standard, as, let's say, appropriate care. Where withdrawing is a frequent element in European ICUs. In Belgium, 40% of the patients that die because of care being withdrawn. In the Netherlands, in the study that we did in 2011, we found it was almost 70% of the patients. So it's a very common practice, but it's not, let's say, comfortable practice for every physician. Now, the ultimate goal of a time-limited trial is to assess the chances of a patient to get to a meaningful outcome. And it's surrounded by the uncertainty. Now, if you look at chances of functional recovery, autonomy, whatever the ultimate functional status is that the patient wants, you have 0% and 100%, and it's clear that at 100%, you don't need a time-limited trial. But it's the uncertainty area. If you're really sure that this will be okay, you don't need a time-limited trial. You don't need to express concerns to the patient. If you're really sure it will never happen, that's of course also not suitable for time-limited trial. It's the uncertainty. And at the other spectrum, you could argue that if you deliver care where you're 100% certain that this will never be reached, that's disproportionate care. That patient should actually not be in the ICU. On the other hand, of course, if there is no debate at all, the patient should not be in the ICU. But it's again the uncertainty. And also here, you have possible disproportionate care. And so this is all appropriate care, and this is the area at both spectra where a time-limited trial could help. That's the easy interpretation of a time-limited trial, but of course in clinical practice, it's much more complex because you have a context. The two spectra, the 2-6 spectra and the 2-well, still, of course, has a context. Patients or family needs time to adapt to the situation. A patient has personal wishes, wants to see his granddaughter being born and stuff like that. There's also resilience. The resilience of some of the patients is very different when you see them to be admitted to the ICU. And you have to take this all into context. And there is no framework. There is not like a protocol. There's not like a standard assessment that would help you. The previous presentation about artificial intelligence, that's probably a way to get this non-biased assessment of your patient. Oh, sorry. And then, of course, there is the question of time. How much time do you need to come to a conclusion? Like, for instance, in this proposal in 2011, it varies from days to weeks, 72 hours to months in some kind of cancer. We're talking about time-limited trial in the ICU. I think on average, that should not exceed the 72 hours. At least you should plan re-evaluation way before. And then, of course, we have to talk to these patients. We have to talk about that there is a chance the patient will die and make sure that the family understands it. This publication found that in many cases, the family doesn't hear it. You say the patient is likely to die, but they don't hear it. So, in conclusion, the presence of a legal background is not universally present. What is easily done in the Netherlands is almost impossible in the United States. Communication is very important. I'm sorry, I don't know why the slides keep changing. Palliative care should be part of the basic critical care training to help us to better communicate. We still have to find the best and optimal timeframes. And what to do if the time limited trial is ended and the family or the patient doesn't agree. Do you extend? Do you make new limits? Or do you force withdrawal? Very dependent on the legal background. There is no framework. There is little evidence or little knowledge about the economic benefit, the efficiency, and also the ethic benefit of these time limited trials. How much, let's say, harm do we prevent with a time limited trial? And there is no well defined patient group or context where it should be standard. And so there's a lot to find out. I think what is very clear is what I said already 3 years ago. Every intensivist should be the best palliative care doctor in the world. Thank you very much.